and then let me welcome you all to the city of Hyderabad. We are known for biryani and pareshani. Our day starts with a Nilofer chai and ends with a biryani, and then that is why we discuss obesity. So, without taking much of time, let me start. So, a few disclaimers which I have. So, yes, this session is sponsored by Eli Lilly, and I'm talking on behalf of them. There are certain rules which are displayed on the slide, which I think all of us have to follow it, because that is what the guidelines of Eli Lilly says. So yes, I have been contracted by Eli Lilly for this talk, and then I've been a part of various other pharma discussions as well. So when we talk about obesity, So when we talk about obesity, I think we all know that why it is important. I think this all 3 days you will see number of sessions being specifically made for obesity, and now I believe all of us know even the definition of obesity has changed. Now we have labeled it as ABCD. So it's no more obesity, we are labeling it, we are calling it as adiposity based chronic disease. You see all of the guidelines, you see the national guidelines, you see the international guidelines, you will see even a small weight reduction of just as low as I would say 5%. Why I'm saying small? Because now we know what GLPs can do. 5% of weight reduction improves the metabolic component. So even at that point, your patients start getting the metabolic benefit, and at 10 to 15%. I think with the drugs what we have, we are talking about 15 to 20%, and with the future more G's coming in, we're going to talk about more and more. So what it does, it is now defining the way we treat diabetes, obesity. It is completely changing the way we are approaching the patients with diabetes and obesity. So there have been two major group of trials done, SURPASS and SURMOUNT. To make it very simple, I think we keep hearing this, certain times we get confused. So SURPASS is on diabetic patients, SURMOUNT is on the non-diabetic patients. So that makes it very, very clear. So you have SURPASS 1 to SURPASS 5. SURPASS 1 was done in comparison with placebo, SURPASS 2 versus semaglutide, SURPASS 3 versus degludec, SURPASS 4 versus insulin glargine, and SURPASS 5 versus placebo. I'm not going to go into details, but today I'm going to talk on one of them, that is the SURPASS 2. But here you will see Mounjaro, when it was seen in comparison with all of them, we'll see SURPASS 1 to SURPASS 5, right from there a maintenance dose of 5 milligrams, 10 milligrams, and even at 15 milligrams, it had further weight reduction, it had a better weight reduction, it had a better A1C control, and more patients achieved the target to treat. So that is where you will see across the SURPASS trials. Today I'm going to talk on the SURPASS 2 trial. So this is a very, I would say, a very interesting study which was done in around 1800 odd patients. We'll see today all of us are confused what to do with GLPs. We had 1G, now we have 2G, we are going to have 3Gs, and then maybe 4Gs as well. So the number of Gs are increasing, the weight loss is happening better, but the million-dollar question still always remains, which drug gives you a better outcome? So this was a study which was done head-on, was Mounjaro versus semaglutide, so tirzepatide versus semaglutide. You will see the patients after randomization were divided into 4 arms. One arm, the patient was maintained on 5 milligrams, another arm it was on 10 milligrams, the another arm it was 15 milligrams. The other arm main where it was compared with was semaglutide, that is 1 milligram. So you will see the important part here is even at the lowest maintenance dose, so that is 5 milligrams of Munjaro, it had a better A1C reduction when you compare it with 1 milligram of semaglutide. So even at the lower doses, it performed much, much better. When we talk about diabetes, when we talk about management, we all know that we are always worried about glycemic variability. So here you will see it sustained A1C reduction was there at every dose till 48 weeks. Again, if you will see when compared with SEMA, it did much, much better. Significantly, all the doses of terzepatide you will see had a better A1C reduction, 5, 10, 15 milligrams. When you compare it with semaglutide, 1 milligram, it had a better A1C control as well. So it was not just diabetes. I think GLP-1s, we are not just using it for diabetes, we are using it for the pleiotropic benefits, we're using it for the weight loss, we want the other benefits. So here you will see even at 5 milligram dose, it had a superior weight reduction versus semaglutide. So even if you will see here, at 5 milligrams, it had 7.8%. When you compare it with semaglutide, it was 6.2%. So just at the first maintenance dose also, the weight reduction was much, much better. I think we were just hearing the plateau by one of the colleagues who were just speaking on obesity. This is very, very important. What happens when we are seen in our clinical practice also, when you start some patient on treatment, on lifestyle, initially you get the treatment and then you always have a plateau. I think that is where it was a real challenge when we were talking about lifestyle medications. Now you see, it's not just that. So entire duration you will see the plateau was not there. There was a reduction which happened at the entire duration of the study. The composite endpoints, again, you will see terzepatide, 5 milligrams, 32% of the patients achieved the target, 10 milligrams, 51%, 15 milligrams is 60%. That is really, really amazing. Semaglutide was with 1 milligram was 22%. Common adverse events. So I would say these are not adverse events. When we talk about adverse events, this is the mechanism of action. GLP-1 acts in that way, so you will have nausea, you will have diarrhea, you may have bloating, but I think all of us have seen within first 2 to 3 weeks, all of these subside. So you have to encourage your patient, you have to tell them that you may develop these, because that is a mechanism of action. It is not probably, I would not say it is an adverse event, it is a way the drug acts. Incidence of hypoglycemia again was similar. You see with semaglutide 1 milligram, so there was nothing much to choose here. So now Mounjaro is the first and only approved single molecule GIP GLP-1 receptor agonist. The 2G superior A1C reduction we have seen with 5, 10, 15 milligrams versus semaglutide of up to 2.5%. Superior weight reduction. I think in a diabetic obese patients, we are looking at A1C reduction, we're looking at weight reduction 13.6%, around 12.9 kgs of weight reduction. I think in our 6 or 7 months of official launch of Mounjaro, we have seen much, much better weight reduction. I think when the patients are on 10 milligrams, the patients are on 15 milligrams, we have seen 16%, 18%. Some of the few patients who were maintaining on 15 milligrams had almost touched even 20%, and still they are maintaining it. So I think probably, yes, it is much and more, we will know. And safety profile of Mounjaro is similar to the other GLP-1 RA. So I would end my talk here. Thank you so much for your patient listening.
Thank you so